Hi everyone, welcome to the Medication Assisted Treatment Community of Practice. It looks like we have some new faces in the room. Can we just have a show of hands if this is your first meeting? Awesome, welcome. We're glad to have you here. So this Community of Practice has been meeting since October of 2018. We have a lot of familiar faces that come to all of the meetings, and then we have people who come based on the topic. And so today's meeting is going to focus on American Society of Addiction Medicine criteria, and we'll talk a little bit more about that for the bulk of this meeting. But before we dive into that, I just wanted to introduce our planning team and then tell you more about the Community of Practice, and then we'll get to the real meat of this meeting. So I'm Rekha Sritara. I am actually covering for Adelaide Murray, who leads this Community of Practice. She will be here shortly. And we are from Community Health Institute, which provides training and technical assistance through the Center for Excellence project. And Melissa Schammel, my colleague, is also part of our team. And then we help coordinate and facilitate the Community of Practice in collaboration with Dr. Molly Rossignol and Peter Mason, and then also Rebecca Skye from the Foundation for Healthy Communities. And this entire Community of Practice is funded by the New Hampshire Department of Health and Human Services Bureau of Drug and Alcohol Services, which includes Regina Flynn, who's on the planning team, and Lindy Keller, who is not here with us today, but is typically here at the meeting. So just a couple of quick things about the Community of Practice. So first, the purpose of the Community of Practice is to really promote and support implementation of medication-assisted treatment in health centers and hospitals. We have a lot of different opportunities that are available through the Community of Practice. We offer these in-person meetings every other month. We also offer resources and tools, which are posted on the New Hampshire Center for Excellence website. We offer a Google group, which is basically like a listserv where you can communicate with all participants of the Community of Practice. So whether that's to ask a question of the group, or to share resources, or to respond to a question, that Google group is available to you. We also do offer technical assistance as needed by practices, and then we do and have in the past offered clinical case conference calls. So if you do have something set up within your organization and you're open to having outside participants, let us know, and we can help facilitate that for you so that others can join. We haven't offered that in a while, but would like to pick that back up. So if you are willing to be a host organization, we would absolutely love that. And then just a couple of, so in regards to the resources that I mentioned, the Google group, if you're interested in joining, and you don't necessarily have to be a consistent participant of the Community of Practice meetings. That's just really open to anyone that has an interest in medication-assisted treatment. You can email Adelaide Murray, and she can get you on that distribution list. Also, resources and tools, as I mentioned, is on the Center for Excellence website. That website address is nhcenterforexcellence.org. And then if you want technical assistance, that also you can request through the Center for Excellence website. There's a brief form, and then when we get that, we can be in touch further about what your request is. So we're doing a little shift in the agenda. There were plans to just start talking about ASAM criteria, but we're actually going to switch to the end of your slide deck, focus on the integrated delivery network. So we're going to talk about that for 5 minutes, and then we'll dive into ASAM criteria. So just want to introduce Dr. Peter Mason. Tell us more.
Actually, that's the only slide we've got.
Yep.
And she gave me 10 minutes, but I'll try to do it in 5 by Eddie. So how many of you know what the integrated delivery network is? All right, so half of you don't. So I'm going to really briefly do it. IDN 101. IDN stands for Integrated Delivery Network. DSRIP is DSRIP, Delivery System Reform Incentive Payment. 1115 waiver. All 3 of those terms relate to the same project. The state of New Hampshire was given $150 million a few years back over 5 years, $150 million, $30 million a year to integrate behavioral health into primary care practice for the Medicaid population, emphasizes for the Medicaid population. And the emphasis is on substance use disorders and serious mental illness. And the idea is to break down the silos between primary care and behavioral health, because people traditionally don't talk to each other, and what happens is primary care people refer to the behavioral health people refer to the primary care people, but there's really very poor integration, and at best it's collaboration. So this is a whole program to break down those silos, integrate care, and have us all live happily ever after. So there are certain elements of this program that I'm going to talk about in a minute. The state was has been broken down into 7 different regions, and what you're seeing here is the map of all these different regions, and you can identify where you are there. The $30 million a year is divided up among those 7 regions. There is an IDN, an integrated delivery network for each one of those regions, and there's a group of people who staff them, and a bunch of projects that go on. The integrated delivery project is the one that is probably most meaningful to you right now, and that's that there are a number of individual practices involved in doing this integration. Anybody here involved in that? Okay, so what happens there's certain key elements of those projects. The first thing is what's called the CCSA, and the reason I'm telling you this is you can hear a lot of this alphabet soup, and it's not going to mean anything to you. CCSA is a comprehensive core screening assessment. What's supposed to happen is every Medicaid patient who touches a primary care practice or a community mental health center over the course of a year, once during that time, gets screened with the CCSA, which includes questions about physical health, about mental health, about substance use disorders, and about social determinants of health. Then a treatment plan is developed, a shared care plan is developed by a care coordinator who the IDN funds. And that person then gets all the stakeholders, maybe housing authority because there's some problem there, or there's food insecurity, mental health people have to be involved, and once a month there's a multidisciplinary care team meeting that is put together for the complex patients in those practices. And all the stakeholders come to that meeting. I just came from one about an hour ago. It was awesome. 5 people were discussed. People heard things that they'd never heard about their patients from each other, and problems are being solved. And that is the idea, that kind of thing happens, and and ultimately all patients, not just the ones who are Medicaid, will be benefits of this change in the way we think about the way we deliver care. We're in the 4th year of this project. There are 16 months left. You should identify people in your region who are doing this kind of work and try to get involved with them. The other 2 aspects of it that are important to you is an IT portion, which is developing a system where you can communicate with other people in a confidential manner about these problems. There are some issues related to 42 CFR Part 2, which if you hold yourself out as a substance use disorder provider, but we're working that stuff out too. And then the last thing is a workforce development aspect of it, which has 4 components. It's both recruiting people, it's retaining people, it's educating them so they can really get into the pipeline, and it's also training so people go up the ladder. And that's basically it. That's the whole district project. It's very exciting. It's going well, and hopefully you're going to be able to access a lot of the things related to the district project as you work with people with substance use disorders. That's it. And I apologize because I have to leave early, and you're in for a treat listening to Paul and Molly.
So two housekeeping items. If you didn't sign in when you arrived, please make sure to do so before you leave. We do need that for continuing education credit. And then also, we do have people joining us by phone. So if you can just make sure if you're making a comment or asking a question to speak as loud as possible so that the people on the phone can hear you, as well as the recording that it captures anything that you share. So 3 objectives. So we're hoping by the end of today's meeting, you'll be able to identify the 6 dimensions of ASAM criteria. We're also hoping that by the end of the session, you're able to interpret the ASAM criteria in an effort to be able to apply it within your MAT practice. And then lastly, we're also hoping that you'll be able to practice utilizing ASAM criteria within the case discussions that we offer you later on today. So without further ado, I'm going to introduce Molly, who's going to provide some context to ASAM criteria and how it really applies to your MAT program.
I guess I don't know everybody in the room. I'm Molly Rossignol. I know a lot of you guys. Family doc / addiction medicine physician. I work at CNC, and I've been working with Rika and the whole crew since I finished my fellowship 4 years ago. And it's really been a great experience. And I feel like I'm sort of preaching to the choir here. So many of you guys probably go, yeah, we get it, Molly. But interpreting the ASAM criteria, this is the book, and so there's a lot more than just saying 6 dimensions. How many of you guys, or did anybody go to Dr. Mealy's conference? So several people went, several people didn't have the pleasure of going. If you ever have a chance, definitely go. So this is really on the heels of that. And I also would say that this is more of, my presentation here is more of an infomercial for what Paula is going to present. So I don't have any slides. I even said, no, I'm just going to kind of give some examples. Thanks. Oh, all right, there's my slide. I was thinking of submitting a picture of my new puppy, but I could have done that. So my infomercial goes like this. You struggle with what to do with patients who seem to only show up for their medications. Or maybe you have some who are doing well with counseling but continue to have urine drug tests that are positive for cocaine. What is an MAT provider to do? So I don't have all the answers either, but I just chose 3 examples that I want to go through and maybe talk through. When we had our meeting, I was talking about, I picture this sort of in buckets. My patients, sort of people who are really doing really well, kind of middle of the road, and then some folks who are not doing as well, and how do we apply the next treatment planning for them. So, and then the big question that came in, and when Paul and I had discussion about this, was where does medication come in? And when I think about medication, I think it comes in at least through the entire dimension. So I kind of feel like, well, what do you mean, where does it come in? We're using medication really as a component, as a treatment for this, for an opioid use disorder, which is why we're all here. In reviewing this, I came across, and I'll comment after each short segment, the concept of significance that I find for my patients. I hope that makes sense. So the first case is a patient that I got about 2 years ago named Scott. And Scott came to me, or I was asked to see Scott actually, who was having a physical exam, and the good medical student who was seeing him asked him if he did sort of a NIDA-1, have you used any recreational, or any opioids recreationally? Do you have any problems with substances? The first thing he said was, yeah, I've been using heroin, and I don't want to do that anymore. He just broke down. So they came and got me, and sort of it turned into more of an intervention and planning. This was a gentleman who was very, very motivated, wanting to get onto treatment. He had been on buprenorphine in the past, but lost his insurance. And as you guys all know, what that does to a lot of folks. And so we, were able to kind of re-engage him in care. He was interested in some counseling. He was interested in attending some mutual help meetings. This gentleman has had a job, actually works double time. This guy walks to and fro to his job, which is about 1.5 miles. So he gets a lot of exercise. He does have a chronic pain issue, and he takes care of a chronically ill spouse. So he, fits. As I talk about some of the things that have been really positive in his care and really beneficial in his recovery. So the things that, when I think about ASAM criteria, again, this is an infomercial, we're going to get more from Paul, but when I think of the things that really he has going for him, because Scott has done well up to this day. I see him every other month now. I give him a prescription for buprenorphine with a refill. And he has, he is regular, he gets to my office on time. He has to use CTS services because he has the expanded Medicaid program. But hugely for him is his housing. He has stable housing, this gentleman does. He also has support from others. He has mutual help groups. He has his wife and he has his coworkers. And then he also has significant emotional stability also within his life and his circles. So for him, medication has made a significant difference. He also has a lot of self-efficacy, and that's somebody who, when I see him, it's more, hey, how are you doing? And he goes, hey, do you mind looking at a rash? I mean, that's sort of our visit. And the concept for this is that this is not an acute illness. We saw specifically that Scott showed up after a relapse. Had he been able to manage not being on medication, he likely wouldn't have relapsed. Medication's made a difference for him. He sees me on a regular basis, and he really does well, and it's still very important to continue to follow through. The other underlying thing I don't want to miss saying is that in some patients, if they do have relapses, we say, well, they didn't take their medicine, or they didn't go to their meeting, or they didn't do this, or they didn't go to counseling. And really what we'd like to emphasize is that patients don't fail treatment. We often fail our patients. If we don't have the options, different options for patients with chronic illnesses, then can we expect them to be adherent all the time if something's not working for them? So my second patient, this is DT. He has been a patient of mine for 2 years, and actually, not unlike Scott, has been doing very well. Working a lot, has a family, has a place to live. DT didn't feel it was really up his alley or part of his world to attend meetings. He really didn't want to go to counseling. Work is really good, his kids are doing well, and so kind of medication was where he was met. He had some emotional upheaval in his environment, and then I started seeing, he called in, he didn't show up. Very unusual for my patient. And then he called in, can I get a bridge? Sure, you can get a bridge, but I need to see you in 2 days. I'll be there in 2 days. He shows up late. He shows up completely disorganized, kind of unusual, very unusual. And I was just like, wow, what's going on? And he had not relapsed onto any opioid, but had started using other substances. So this is sort of my kind of, we're going to see as in this chronic illness, potentially relapses. So looking at, again, the dimensions, what kinds of things can we incorporate to maybe bring him back into treatment, help him get to where he wants to go? And the first thing I said to him, what are you looking for? What do you like? What would you like? He's like, well, I gotta stay on my medicine. Do you have any suggestions for me for, where I could go for counseling or, you've talked about those mutual help meetings, or 12-step or whatever. Which one do you suggest I go to? And so I made some suggestions. The concept of this, and so he is, he's still in my practice. He has shown up a second time, and urines actually are good at this point. But I know that that's not like, oh, sure, we're through and we're fine. We continue to follow. The concept to this is really the high variability in someone's drug use course. Not everybody just stops. They may try something different. They may, their lives may bring them to a point where they need something to change how they feel. And so managing the ups and downs in somebody's experience. The other concept is that certainly personal characteristics of individuals are going to drive how people do, including their psychiatric comorbidities, their home environments, and then of course the social determinants, which I'm learning more and more, as we all are, these social determinants that really can drive how people respond to any type of medical care or health crisis. So ASAM criteria address much of these. What do patients want? That's one of the questions that Dr. Mealy brings up a lot. We may want something, but we really need to know where our patients are and where we want to meet them. One of the concepts that Dr. Mealy brings up, and I'm sorry if I'm stealing your thunder, I don't want to, but oftentimes, good, I'm almost done. Oftentimes we talk about recovery and abstinence, so that's the goal. I mean, yeah, that's the goal. I love recovery and abstinence, but sometimes we need discovery and then prevention of drop-off prevention. So really, let's get DT back in the clinic. Let's make sure he's doing okay. Let's find out what he needs. And then the last person is really sort of that, I'm not sure, I feel like I used to euphemistically call folks, bucking broncos. It's like, all right, well, let him buck for a while. Let's see where we can help him. So I've got a couple of people on my practice like this, so I wrote myself some notes. ASAM, and he clearly, this gentleman is somebody who is homeless. He has mental illness. He has a bunch of ACEs. He clearly meets criteria for a higher intensity of care. I have referred him on multiple occasions. We have called places while he's in the room with me. But, of course, you can't always, what does he want? And so usually when these kinds of things happen, what happens? They either don't go or they do. And fortunately, SM did end up going to a higher intensity of care and has come back and, is working his way to maintain some semblance of okayness or wellness. And the concept here, what I mentioned, I'm seeing more and more folks with social determinants of health that really are going to significantly affect them. So his living situation, finding some stable living, which he was able to achieve, the social supports are so significant compared to even the first two examples, and really helping folks to find that sense of support. This comes in where Dr. Mealy talks about, are they doing treatment or are they doing time? Because it took a long time, though it sounds like he got right into treatment. These were months of visits where his urines were still positive or his saliva testing was still positive for multiple substances. I didn't have to do that to tell me what he used. So really, are they doing treatment or are they doing time? I still feel like even if people are just doing time, in the context of using buprenorphine, I do feel strongly that we may be the only point of contact for folks. He's still showing up. Why are you showing up? Why are you showing up, SM? And he says, because I feel like you're the only person who listens to me, and I believe him. And so being that, at least constant person, even though I made him come in every week, and do very, very short medication prescription. Lastly, and I know I only have like 30 seconds, 3 minutes. Oh. Let's see, looking at ASAM criteria strengths. Oh yeah, finding strengths in patients, finding what their strengths are. Because clearly, when I think of SM, he walked to my practice. He had the endurance, if you will. He had the stick-to-itiveness to show up, and he eventually did find his way to a residential facility where he felt really, really well cared for, and that even has some bumps in it, but felt supported and trusted enough, and I consider that one of his strengths. When I asked myself, could this just be the medication only? Is that why people are coming to see me? Is that it? There is one provider that I've talked to before that claims that everyone's going to use it as a currency. Maybe some people are going to use it as a currency, but that's not the way that I look at my patients. And I think, well, it may be, but there's certainly testing we can do, which we've gone through that in our community practice. There's checks and balances that we can perform with our patients. We can do patient evaluations, and then also if we're able to get collateral information from others. which I take advantage of, provided that they've signed consent. And looking at when Paul gets up, he'll talk about, I'm sure, continuum of care, which is really what ASAM criteria looks at, but making sure that we have an opportunity for monitoring, because that's pretty important. Again, I come back to keeping patients in our practice. That's really important to me. I want to see people continuing to show up. And then even after months and years, I have patients, as I said, who have been in a couple of years. This is a chronic illness, and it's really important, just as if we were monitoring somebody with diabetes, hypertension, high cholesterol. We want to see people come back so we can say, hey, how are you doing? Even if we know, hey, their A1C has been 6.5 for 3 years, we still are monitoring because that illness is still there, just as we know this illness is around. The last, I'm just going to say, my fantasy of, do I have 1 minute? My fantasy of monitoring folks would be, online tools, apps, which there are some apps that are coming out. Maybe someday we'll do a COP on the sort of the tech and media, social media for caring for folks with substance use disorders. I know we've talked some about telehealth with some of the providers here. Could we have 24/7 easy walk-in services for mental health? Could we have, beds available all the time? That would be terrific. And that's my intro, just regarding some of my experiences. Paul, I'm introducing you, Paul. So, Paul, Kiernan or Kieran?
Kiernan.
Kiernan. Paul Kiernan is an MLADAC who I met at Concord.
I'm actually just a LADAC.
He's a LADAC. And working for Center for Excellence. And I have seen letters to Dr. Mealy about you, so we forged a relationship with Dave Mealy. So he's going to be.
Oh, the teaching topics.
Back and forth. Yeah.
I thank you for the segue. It's probably one of the best ones I've had. I'm already standing up here with some of the folks that are here today. Historically in SUD treatment with folks like JD, I forget the initials, but we said, well, this is what you need, not, asking the question, what do you want? And I think I love hearing things like that because that's the direction we need to head in. So, my youngest daughter came to me with a video. This is my one anecdote I love. And it was like, a 3-minute rap song that summed up like a 100-minute movie. And it was this guy doing, that's what I'm about to do for all of you, so I apologize. I'm giving you tons of information.
You're going to rap
very
for us?
quickly. I'm not going to rap. But this is, it's a lot of information. For those of you that saw Dr. Mealy, it's going to be a lot of the same stuff. For those of you that weren't there, I'm going to just try to keep up because it's a lot of information. I live in this world, and the more I learn, the less I know. So, I'll give you what I can. And I've been told I got to keep my anecdotes down to a dull roar. So I'll get started. So the American Society of Addiction Medicine ASAM criteria. When we talk about ASAM criteria, we are talking about the book. For those of you that don't have the book, that are interested in ASAM criteria, I very much suggest you buy it. Everything's in there. Everything you need to know is in there. But what we're talking about is patient-driven lengths of stay. Historically, SUD treatment has been insurance-driven. It's been fixed lengths of stay, 28-day programs, things like that. ASAM is really all about patient-driven lengths of stay. If I have a broken hip, how long am I in treatment for? Until I meet my treatment goals, until I heal that broken hip, not a fixed length of stay. Non-program or curriculum-driven treatment. So the individual who has no criminal history is sitting through lessons for criminogenics and has been gainfully employed is not supposed to be sitting through that curriculum. It's not appropriate for their treatment goals. Really working at discharge or continuing care, looking at that continuum of care, beginning at intake versus scrambling to do it at the very end. Continuum of care versus graduating treatment. Okay, it's not, oh, you've completed, here's your certificate, good luck. It's, what's the next step? What's the next prescribed amount of treatment for that individual as we move forward. Completing a dimensional assessment, we're going to talk about that, and continuing to assess. So, as the examples that Molly provided, you know, if someone comes in, now I'm looking at, okay, I'm doing a six-dimensional analysis. Okay, this person's using another substance, I'm gonna look at dimension 5, assess what their continued use or problem potential is, and kind of go from there. So, ASAM criteria, there are 6 of them. I'm about to go over all of them to this slide. I'm gonna skip right across. So dimension 1, okay, when we talk about dimension 1, we're talking about acute intoxication or withdrawal potential, okay? So we're not only talking about, you know, what's the potential for withdrawal, or what's the level of withdrawal they're in, but it could also be for intoxication if they're under the influence of the substance, to what degree. What are the risks associated with the patient's current level of intoxication and withdrawal? Is the person intoxicated and planning to bike, drive out of there? Are they going home to their 2 small children and no one else is home? What's their level of intoxication that they're going to be doing those things with? So we want to look at that. We want to get a substance use history. How much, how often, how, and how long. All of those things are going to change the level of withdrawal they could experience, okay? We want to look at, obviously, you know, how are they using it? You know, the method of use is going to change bioavailability, is going to change the potential for withdrawal. So we want to get all that information. We want to focus on here and now. We want to get the history, but here and now is going to trump history, okay? If the individual is in severe withdrawal, but they don't have a history of any kind of seizures or problems associated with that withdrawal, we're still going to take the here and now, and vice versa. Current withdrawal symptoms, withdrawal history, okay? Again, we want to get the history, it's important, but we also want to find out what's going on now. We also want to know that if they are intoxicated, and we know how much they've been using, they're not in withdrawal now, but boy, they're going to be soon if they don't have any more substances. We want to get a CLAW COWS or CINA score, very important, because it's something to kind of continue to assess with. We also want to collect that information, but have someone who is able to interpret the changes in those scores as they go forward. Assessment of a multidimensional interaction, we'll talk about that. Consider the patient for withdrawal management services, okay? Either ambulatory, which a lot of people don't even think about, or residential, or inpatient, I should say. Dimension 2, biomedical conditions and complications. Current physical illnesses, chronic medical conditions, pregnancy we want to look at, multidimensional interaction, special attention to dimension 1. So an individual who has a history of a seizure disorder, you know, we know that opiate withdrawal alone is not going to cause a seizure, but if someone has that history and they are in opiate withdrawal, we know that an overexcited central nervous system is probably going to make them more likely for a seizure. So we want to look at those things and how they interact. We want to look at physical illness as how it's going to interfere with their ability to take the prescribed treatment for their substance use disorder. For example, we don't want to send someone who has, I don't know, serious hypertension, active Hep C, whatever it may be, you know, to a residential facility without any medical personnel on board. Dimension 3, emotional, behavioral, or cognitive conditions and complications. So we're talking about current emotional, behavioral, or cognitive conditions that could interfere with treatment. Chronic conditions, relation of symptoms to SUD. So we want to find out, you know, with protracted withdrawal or post-acute withdrawal, there can be a connection of symptoms. Like going through a craving for a substance is a very anxiety-producing situation for folks. So you want to know, are you dealing with an organic anxiety disorder, or are you looking at protracted withdrawal? What are the relations of their symptoms to SUD, okay? What are the chronic conditions? You want to find out a mental health history and the treatment history. A lot of folks come in, and most people are anxious and depressed, and most people have reasons to be experiencing symptoms of dysphoria or depression, and most people have a reason to be anxious. Their PO's threatening to throw them in jail, their wife, their husband's going to leave them. All these things are going on, you'd probably be anxious too. But what's going on? Also, you want to find out their diagnostic history. Someone says, I have a history of major depressive disorder. You hear that, and a lot of people panic, and they're like, well, this person needs a very extensive level of care, inpatient, but if you ask them questions like, what's going on currently for you? Well, I'm kind of down, That's not major, you're getting out of bed, your ADLs are okay. So you want to do that screening process to find out what's going on, and find out if you need to, if you're not the properly credentialed individual, to screen them out, or to continue to monitor their symptoms to see if they improve or get worse with abstinence. So you want to get that treatment history. A lot of people come in and they're like, oh, I'm a little bipolar. It's like, I don't know what that means. I'm not mental health, but, you know, I still don't know what that means. They're like, well, I get a little moody sometime. I was diagnosed like 5 years ago. I was using, you know, cocaine, and this is what's going on. Well, you know, I don't know if I'm dealing with organic, you know, obviously monitor and things like that, but I'm screening and doing some looking at that, like, I don't know if this is, you know, that's what we're dealing with here. So if you want to find out that history, you don't want to panic when you hear that history either. TBI history, I started this one because a lot of folks don't ask a lot of questions around this. You know, we ask, have you ever had a traumatic brain injury? No. If you had asked me that for years, I would have said no. And then after we learned more about concussions, you know, the bus ride home from the freshman football game when I was like, okay, I'm on a bus. I'm like, you know, I played the entire game, don't remember any of it. You know, I probably had a little bit of a concussion. So you want to ask questions. You ever have a period of time that you don't remember? You know, we ever hit in the head, you know, things like that. Becoming violent, you know, ill after a head injury or a collision. Actually, you probably just asked, do you ever play football? That's a good segue. Monitor symptoms, or hockey, yes, or any contact sports, absolutely. Monitor symptoms, this is an important one. You want to continue to monitor symptoms. You want to continue to assess. That's one of the paramount kind of points for ASAM, is continuing to assess dimensionally, thinking of those dimensions in your head. Monitor symptoms. And again, a multidimensional interaction. If you have someone who, you know, you're looking at and you're kind of doing a screening, you're looking and saying this person, you know, has an untreated anxiety disorder, which is a large population of individuals with alcohol use disorder or an untreated generalized anxiety disorder. You know, are they drinking to self-medicate themselves? So you want to look at how those dimensions interact. I'm leaving so much out, I apologize. Dimension 4, readiness to change. Okay, this is like my favorite dimension. This is like the motivational interviewing-ish, you know, this is one where you kind of get to do those, that work. This is really all about assessing the individual's readiness to change, you know, not only readiness to change, there's more to it than that, looking at their, you know, their level of self-efficacy, what's their belief in their ability to change. You know, you do that, whoever's familiar with that kind of readiness ruler, you know, how important is it for you now to change? It's always like a 9 or a 10 because they're going to go to jail or they're, you know, they're going to lose their kids or some awful's going to happen. All right. But if you then even ask them, how confident are you? They're like a 5 or a 4 or a 3, you know, because they've had bad experiences in treatment a lot of times. They don't have that level of self-efficacy. They can't picture their life without the substance. So you want to, you know, you want to find out questions along those lines. Mental health and SUD assessment, you can assess what's their readiness to change to address a mental health disorder as well. Patient's level of awareness of their relationship between negative consequences and substance use. I had a patient one time, I was doing an assessment, I don't know if Monica remembers this, but I remember doing this assessment and, you know, I said to her, you know, she was telling me kind of reasons that it wasn't that bad. And I was listening and doing a lot of motivational interviewing during the assessment. And she said, well, I don't have any scarring, you know, and she's, you know, pointing at her left arm where she used IV fentanyl. And I need to mention, this woman had these 2 fingers on her left hand amputated because she had a horrible infection from IV opioid use. So the disconnect between the consequences of her use, you know, those cognitive distortions, that distorted thinking is so paramount in this illness, and you want to assess, you know, what is the person's understanding of, you know, the problems in their life that they associate with their substance use disorder. What's their level of awareness? What's their readiness, willingness, ability to change addictive behavior? What resources do they have? What's their, you know, level of self-efficacy? You know, if you have patients who you're like, you know, what are you willing to do, you know, in order to do this? Like, what aren't you willing to do? You know, you can find out a little bit more about, you know, what are some of the things that they're willing to implement in their own care. So you want to find out, you know, kind of where they're at. What are their goals for treatment? Not your goals for treatment. What are their goals for treatment? So if they're coming in and they're saying, you know, everything's fine, well, you know, your probation officer called and said, you're testing positive for, or you're not testing positive for buprenorphine, which I'm prescribing you, or you're being prescribed, but you're testing positive for cocaine. What's going on? Okay. You know, well, find out later the patient's goal for treatment is really just to get their probation officer off their back. You can kind of work with them on their goals and how their use can kind of get in the way of their goals. Multidimensional interaction, again, someone who has significant problems at dimension 4, there's a disconnect between their use and their problems, things like that, is going to have a heightened increase in problem potential in their dimension 5, relapse, continued use, or continued problem potential. You still with me, everyone? I'm losing myself, so hold on. All right, both SUD and mental health can be assessed here. What's the potential that they're going to have continued problems with their mental health disorder or psychiatric disorder? You want to, find out what strengths, coping skills, ability to manage cravings, impulse control they have already. When you talk to clients a lot of times, or patients a lot of times, so what do you do? What happens before you use? What do you mean? I just get high. Okay, cool. Now you kind of know what you're working on. Well, tell me a little bit more. Like what's the internal dialogue you have? Well, it's this horrible battle that I have. And if you really talk to patients, they'll describe this to you. And a lot of times, they don't get high because they want to. They get high because they're tired of fighting with themselves. And that's really what I've heard over and over and over again, is that it's like, I just couldn't, I got so tired of that battle. So you want to find out, is there some inner resistance? Is there some consequential thinking happening, that you can kind of build on? Do they even know what a craving is? Have they had prior treatment? Things like that. Understanding relapse versus continued use potential, I can go on, and I could do a whole day just on this alone, because there's a very big difference between someone who is continuing to use and someone who is trying to not use and is engaged in treatment and is relapsing. There's a very big difference. And historically in the SUD field, we have addressed both as relapse problems. Oh, you're continuing to use? Well, you better stop using. Let's give you another relapse prevention plan and see if that works. Well, it's not working because they don't need a relapse prevention plan. They need a discovery plan. They need a way for them to identify that the problems in their life are caused by their substance use disorder. It may be plain as day to us, but it's not to them. So understanding the difference between the two. Again, getting a relapse history, this kind of ties into the first bullet point. What's the internal dialogue that precedes a relapse or precedes their continued use? Relapse doesn't necessarily mean a more intense, this is an older slide, a more intense level of care. Try not to think in that lower, higher kind of hierarchy. Relapse can sometimes mean, or return to use can sometimes mean that the person needs to kind of work out that ambivalence in a less intense level of care. The knee-jerk reaction still happens today is, they're using an IOP, well, they need a more intense level of care. We got to get them to residential. Well, not necessarily. Okay, you want to take, obviously, if they're an imminent risk and imminent danger, even though they may not believe they need it, if they're in imminent danger, you can kind of mandate, or not mandate, but insist on that more intense level of care. But if they're not, if they don't meet that threshold for imminent danger, moving them to a less intense level of care where they can resolve that ambivalence is oftentimes the right prescription of treatment. What's the patient's awareness of cues or triggers? Do they know what a cue or trigger is? Multidimensional interaction, again, you're going to look at how these dimensions interact. Someone with low readiness to change is going to have a much more higher risk or higher potential for continued use. Dimension 6, recovery environment, both SUD and mental health disorder assessment. This dimension is interesting. It's kind of where you can throw a lot of things. Spirituality gets thrown in here, work, family life, a lot of things, recreation. A lot of different supports that they have. Again, you can assess both mental health and SUD here. Threats to patient safety or engagement in treatment. If you have a patient who is returning to an environment that is a lot of use going on, you're obviously, that's going to affect other dimensions. We talked about that dimensional interaction. Resources available to help with the successful recovery. We live in an interesting state. If you're in the North Country, it's a different culture, much less resources. You're already at a higher risk in Dimension 6, okay? Less availability of resources. Transportation, childcare, housing, or employment issues are going to go here. I really, I'd love to do an IOP program. I think that's what I need, but, how am I going to get there, I have a child, and, I can't, I don't have a car. I really want help, but I got so much going on. And then they just kind of give up. Mandates that influence treatment motivation. I've been pretty lucky throughout my career to work with really good probation officers usually, that are willing to kind of become part of the treatment team. Because when they mandate, other folks not so much, but and a lot of them are just so busy. But when someone's mandated a treatment, the first call is after you get that consent forms to the individual mandating, the probation officer, the wife, the husband, whoever it is, to say, this is where we're at. We'd like to kind of get everyone on the same page. Well, it's kind of like welcome to the treatment team. Spirituality can be assessed here. Multidimensional assessment. Again, I can't stress that enough. These dimensions are not static. They do have a play. ASAM criteria risk rating. So the 0 to 4 rating. 0, this rating would indicate a non-issue or very low risk. This patient will present no current risk or any chronic issues, would be mostly or entirely stable. I really don't want to bore you reading through this. You have it all in front of you. I'm also trying to buy myself some time, really. So you have these in front of you.
Paul, it's okay, I'm buying time.
You're buying the time.
I'm on it.
All right, so it's a 0 to 4 scale. Now, there's a lot of folks at ASAM that there's a lot of discussion about not doing away with this, but not such a focus on the 0 to 4 scale, because while it is helpful, what's more important to me if I'm looking at an assessment is why. Why a 1? Why a 2? Why a 3? Why a 4? Especially why a 4. Okay, we're talking imminent danger mostly when we're talking about 4. So, it's great to have that number, because if you're trained in ASAM, you know it well enough, and the person giving you the assessment is well trained in ASAM. This is why I came from BDAS, working for BDAS, and I would audit records, and I'd look at, everyone's like, oh, it's a 4, 4, 4, 4, 4, and I'm like, look, why is this person not in a psychiatric hospital with medical care, withdrawal management? So if you're looking at that, the rating scale is helpful, but what's more helpful is the information. So if someone is saying, it's a 1, this is why it's a 1. This is the history or these are the problems. And that will help you with your treatment planning. If you're looking at those things and you have information on these dimensions, now you have your problem statements for your treatment plan. And when you have your problem statements for your treatment plan, you're more than halfway there, all right? A good problem statement is the best jump off for a good treatment plan. So now we're kind of ramping up. One is, it's a mildly difficult issue. It presents minor signs and symptoms. Any existing chronic issues or problems would be able to be resolved in a short period of time, okay? This is someone that might have some generalized anxiety. They have some symptoms, some things that might not be directly related to protracted withdrawal. But if we teach them some recovery skills, those recovery skills are going to kind of translate across the board, and they're going to be able to implement them to deal with any anxiety. 2, this is would indicate a moderate difficulty in functioning. However, even with moderate impairment or some persistent chronic issues, relevant skills or support systems may be present. Okay. Yeah, I have this really bad anxiety, but this is how I've dealt with it all this time. Okay. It is a problem. I do have it, but I've been able to manage, and this is how I've managed. Yeah, I have this history of major depressive disorder, but what they describe to you is some dysphoric kind of symptoms. You want to monitor that. You want to see if it's getting in the way. If all of a sudden they're saying I didn't come to treatment because I couldn't get myself out of bed, now we know we're ramping up and we need to this thing needs to be triaged in our treatment plan. 3, this rating would indicate serious issue or difficulty coping with a given dimension. A patient presenting at this level may be considered in or near imminent danger. Okay? Imminent danger is a whole other talk on its own. So 3, this is something that really is going to drive a patient's care if they end up at a particular level of care in most cases. 4, this rating would indicate an issue of utmost severity. The patient will present with critical impairment in coping and functioning with signs and symptoms indicating imminent danger concerns. And again, see your handout for easier reading. So 4 is like someone who's not going to leave your office without a treatment plan. This individual that Molly describes who kind of broke down, probably had some things that were of that severity. Where it's like, okay, let's bring someone in and make a plan. Levels of care. I'm going to fly through this as well. All right. So we talk about early intervention, outpatient services, intensive outpatient, partial hospitalization, residential, and medically managed. All right. We'll go through those briefly. Level 0.5, I came up in the treatment field. I've always had this mindset that treatment and prevention are two totally different separate things. They're not. Okay, early intervention is treatment. Early intervention is prevention. Hey, you got a DWI. You don't have a real significant history. You don't meet the threshold for any diagnostic criteria, or not all of the diagnostic criteria. But let me give you some education to prevent any further problems with alcohol or drugs or whatever it might be. These are typically like DWI programs, work programs, things like that. Not sufficient information for a diagnosis. That's not entirely accurate. Maybe, there's not the information provided. If there's not sufficient information, you should be getting more information. But you have the information, and the person is still, you get some collateral, which is really important. And they're not meeting that criteria. Provide education, screening, risk factors, things like that. Outpatient services is level 1, organized services in a wide variety of settings, professionally directed evaluation, treatment, and recovery services, regularly scheduled meetings. The thing I want to impress upon you with level 1, again, without thinking of insurance obstacles, this can be up to 8 hours a week. Okay, so when we think of outpatient services, a lot of us think of that either group or individual, that 1 hour a week kind of thing. It can be more than that. If you have someone struggling, it's not like, oh, well, I'll see you next week, but good luck. It can be, hey, let me see you on Friday. I have a quick hour window that you can pop in, or even a half an hour. You can pop in and we can see each other, because I know you're having a stressful week, the anniversary of the death of your daughter, or whatever it may be. So it doesn't have to be that strict 1 hour session. 2.1 is your intensive outpatient programs, organized services delivered day or evening hours to accommodate work, childcare schedules. Patients provides patients the opportunity to apply skills learned as they learn them. They're in an IOP, they're going to work, they're living in their environment, they're still, walking down the same street, bumping into the same folks. They can apply those skills as they learn them. Regular consultation with psychiatric, medical, and medication management, hopefully. 9 or more hours a week for adults, 6 or more hours a week for adolescents. Any of you have adolescent children, you know why it's 6, not 9, okay? Partial hospitalization services, direct access to psychiatric, medical, and lab services when warranted. Provides 20 or more hours a week of services. It does not need to be a hospital, and it is not a residential treatment facility. It's often two misconceptions with this level of care. Typically, you see a ramping up of either Dimension 5 or Dimension 3 issues that would warrant admin to this level of care. Clinically managed low-intensity residential. This is kind of like a transitional living or halfway house, 24 structure with available trained staff. So if Jane gets a craving at 5 o'clock in the morning, she's got someone trained that she can talk to. That's the difference between this and just a sober house. A minimum of 5 hours of clinically supervised, clinical services per week, okay? And that's with a licensed trained professional. People work in the community, they drive, they come and go a lot of times in these facilities. Clinically managed population-specific high-intensity residential services. This is a level of care we don't have in the state, and we really don't have in the nation. This is only an adult level of care. 24-hour care with trained professionals to stabilize imminent risk. Less intense to accommodate the needs of patients unable to benefit from a more intense application of treatment, typically for patients with developmental disability or traumatic brain injury. So this is a level of care that's very patient-specific for folks who can't really tolerate a normal patient milieu. Okay? Clinically managed high-intensity residential, if you ask my opinion, which you didn't, but I'm going to tell you anyway, this is the most confused, not utilized the correct way according to ASAM level of care we have in this state. Okay? It's the 28-day programs. We house them for 28 days. We call it individualized care, but we still keep them for 28 days regardless. Everyone just happens to end up there for 4 weeks. Go figure. It's really meant to be imminent danger. You stabilize that imminent danger, and you look at that continuum. Okay, where do we go from here? Let's get this person back to their life. Let's get them, functioning where they need to be. So we're talking about 24-hour care with trained professionals to stabilize imminent risk. Patient can't get from point A to point B without using, and their use is creating problems in their life that is going to either seriously harm themselves or someone else. That's what we're talking about. Nobody knows what to do with them, so we're going to house them for 28 days. We're talking about, stabilization. Patient must be able to tolerate and benefit from an intense milieu or therapeutic community. They also need to be able to do this without medical care. So if someone has a ramping up of, we'll get to that in the next slide. Now we're talking about inpatient. We turn from residential to inpatient here. 24/7 nursing care, physicians available, similar to 3.5, but with in-house access to acute medical or psychiatric care for individuals with significant problems in dimensions 1, 2, or 3. So those are the dimensions that are really going to there's going to be an effect in that is going to create the need for this high intensity level of care. They either have significant withdrawal risks, significant biomedical condition risks that are going to warrant them going to an inpatient facility or significant psychiatric concern. Level 4, this is 24/7 nursing care with daily physicians care for severe unstable problems in dimensions 1, 2, or 3. Counseling services are available, but if someone is in active psychosis, doing motivational interviewing with someone who's not fully oriented is oftentimes not effective. But when they, do kind of come around, you can kind of intervene. Although an SUD diagnosis is needed, patients' acute needs are addressed. Okay, so if they have a severe psychiatric disorder, you're addressing that. Opioid treatment services. Okay, we talk about agonists, medications, and if you want more information on that, I highly suggest you get the book. Page 290 starts the whole section on medication-assisted treatment of opioid treatment services. When it talks about agonist medications, antagonist medications, what kind of crucial require here? Can be and oftentimes are bundled into other services, other levels of care. Opioid treatment programs, your methadone programs, office-based opioid treatment. So if you want to look at page 2, the pages I think are most important are 296 to 299. They really give a real good crosswalk of who's appropriate or how to figure out who's appropriate for opioid treatment services. And boy, I'm glad I'm done talking. So that's a lot of information. That's a ton of information, and that's a small bit of it. We'll talk more about this going forward, about how to kind of assess someone, how to continue to assess them, and so on and so forth. So questions? I guess we'll take some time for questions. And again, I'm going to probably talk a little bit to Molly, with some of these. I'm not an MAT expert by any means.
For ASAM criteria.
ASAM criteria, I know.
Are all, include alcoholism.
Yeah.
ASAM criteria, all substance use disorders. Absolutely. I'm sorry if I wasn't clear about that. Yeah, you're looking at everything here, and that's a great point because when you're looking at, you're all in MAT treatment, so anyone have a client who likes to smoke pot, but
Or cigarettes, for that matter.
or cigarettes, or things like you can assess differently for different substances. Yeah, they're action stage for their opioid use, but they're pre-contemplative given their marijuana use. They wish they're looking to get their card. So yeah, you want to look at different substances here. Thank you for clarifying.
Does insurance not cover coverage in agencies, organizations that don't use the ASAM criteria?
So 2 years now. For 2 years? 2 years now. New Hampshire is an ASAM state, so insurance companies in the state of New Hampshire are required to utilize ASAM criteria. Some of them say, yeah, we do it, and they don't really do it. Some of them say, yeah, we do it, and they really do. So they're required to use it. So as a clinician, I've really advised people that if you use the book and be like, well, on page 296 it says right here, blah 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 blah, and then you get the insurance company on the other side going, it helps you get that authorization because you're basing your things on what they're supposed to be using.
This patient that is using other substances as well as their Suboxone, being them for a while, let them need to stop. He's impulsive, gets very angry, will walk off bad eventually. At what point do you say we need to go with feet to the fire and we need a higher level of care if you can't come with weaning you down, and that's how it's going to be?
So The one thing, I'd like to hear some of your feedback on this one, but my recommendation would also be not to immediately look to a more intense level of care, but to look at, okay, well, what are the motivations for them to discontinue that use? You know, not, well, gee, we just need to throw more treatment at them because then they'll stop using it, because a lot of times that's not the case. What happens is you put them in a more intense level of care, they become more resentful, more angry, and less likely to change.
But what he's already said, not doing it, the hell with it, and the only reason they're around is they have to sick somebody at home. At what point do you keep giving them the medication just because we're at least helping them, even though he's not going to do anything else?
I think that's the $1 million question that it's me right now, is it not?
But
Yeah, if you don't mind.
well, I would say, you know, that we're treating addiction. You know, we're not just treating, again, we're not just using medication to treat
I understand.
a dependence. We're treating addiction and, you know, looking at, again, what are your motivations and, for example, I don't know if you're talking about somebody using cocaine or methamphetamine or, you know, there are some things that we ain't got a prescription for, you know, and we can do our best to help the person come sort of that discovery, if you will, discover why it may be a good idea. How is that limiting them moving forward? And I have patients who are always positive for cocaine. I'm not going to stop prescribing them buprenorphine because you know what? He's got a big scar, looks like shark bite, because he had to have surgery, and that thing hasn't changed for 3 years. He hasn't put a needle in his arm. He continues to take care of his family. He does have a PO to you know, face, and I say, you know, let's talk more. We talk about motivational interviewing. We talk about some of the consequences and some of the strategies he could employ, and what do you want? What do you want? And he says, I want to stop. But so no, I'm not going to threaten. I used to, but we've evolved. I mean, the stuff that that happens on the street is going to kill them. And what's the better? What's the better? And so, you know, it sounds to me like it's frustrating, and I agree, it is frustrating that patients don't do what we want them to do, and we know it's better for them. But you know what? We're not the ones with the problems. We're not. They're the ones who are struggling, and so we need to continue to be there for them and to do the next right thing. I mean, if it looks like they were selling our prescriptions, now that's a different thing. But if they're taking the medication as prescribed, that's the way I look at it. We need to be supportive.
And this is where, you know, that whole, you know, ASAM and motivational interviewing that work with Linda and Rome that kind of intersects. You know, if you allow them to be honest with you and share those things with you, that this is what's going on for them. If they do get to a point where, like, they're using cocaine and, you know, I used opiates, you know, it brought me to opiate use, kind of that landing gear thing they call it, you know, I was using cocaine and I got busted. You know, they're more likely to kind of share that information with you if you allow that kind of open dialogue with them. But if you become adversarial with them, like, listen, I'm gonna cut you off, and you know, you're gonna need to go to a higher level of care. They may be less likely to engage with you. So, other questions?
Intervention or other intervention that we don't stop.
And that's the whole thing, you know, that David Maley was teaching, and for those of you that were there, it's like, you don't like come in and say, oh, you said positive for cocaine and then buprenorphine, okay, I'll see you next week, like, that's no, you know, but if they're engaged in treatment and they're doing treatment, and they're not just doing time, you continue to work with them, obviously. Other questions before we move on?
The highest level of care here, I mean, you can have people in residential treatment, right? If they're in there, we don't have involuntary admission.
We don't.
Well,
In
in some states,
Some states do.
Yeah. So they can sign themselves out, right?
Yeah, absolutely.
That's, I just throw that out as a problem I'm continuing to raise, because the feeling that I'm doing is that, two in particular, with alcohol, and they really are, attractive. And it means that they admitted themselves out.
And we could go down a very deep rabbit hole there, so.
I do all the time.
If you're interested, the treatment task force is working on that project.
Yeah, I wrote a very long report on all that, so it's just like more information.
You talked about the level 3.3 residential service not existing really anymore. What is our focus on that? Looking more like a traumatic brain injury site.
And that's a whole other debate. You look at overdose and oxygen deprivation and how many people actually have, traumatic brain injury that's not documented, and didn't even go there. But and without the substances and things like that. I don't, and Molly might have a better suggestion, but it's, depending on which is more severe, like if they're, if the TBI or, whatever it may be, the DBD piece, whichever is more prevalent, you might want to address it there. Like if they have a very significant traumatic brain injury, some form of treatment for TBI, and then you throw the substance use treatment on top of that, either through, work with other agencies, or if the person is kind of able to function, you treat them in an SUD treatment program with the understanding that they may need, their treatment plans are going to have to be augmented even more, or kind of tilted even more to address any difficulty they may have understanding or comprehending or applying, because most of your CBT treatment, getting away from MI, most of your SUD treatments has a CBT component to it. So there has to be that level of ability to comprehend and apply the treatment. Yeah. So maybe coming at it from the TBI or the DVD kind of lens, and then bundling on some SUD services would be the best way, unless you have a better suggestion.
No, I agree, and at CMC we do have a rehab unit, and actually the director of the rehab unit is here, and he's also a MAT provider, and we've had patients there who came in originally with cardiac effects of IVDU and ended up having a stroke, and so he went to the RMU, and so was able to get some treatment. It wasn't TBI per se, but then, I was also consulted, so that was the only kind of put together. While that individual was hospitalized, I did look around the country, and there are a couple that are TBI specific, but they're very expensive and very exclusive, and, but there was a place in Minnesota, I was going to look up the name of it again, but there are some very specialized places.
Other questions?
Not related to all things that we discussed. In the last week, I have 5 of my patients asking for the master presentation. I never had it before. Any of you have questions of patients asking for the negative idea of it?
I haven't, but you're in Nashua, so, wait a week, I'll let you know.
I think I have to bring it because I did not have any patient asking, and last Thursday was the first one, and today was the 4th, asking for the patient.
Did you ask why? Like, that's what I'd say, hey, what's going on?
Please, and nothing
Well,
worse.
why are you asking that for that? Like, I'd say, why are you asking for that? It's really peculiar.
I asked, why do you want? Because it's the only thing that makes me sleep. It's that work,
Did they tried it
Oh,
already?
yeah,
And that's why
they did try. So that means
It's an ingredient, something hard.
So Chad
Enhances the
Chad Peterman have a source from it, Sonata.
I try to steer away from Z medication, the
Yeah.
sleepers like that, because we know of the, benzodiazepine, like effects, so I
No,
don't.
I
It's not
know
something
that, I'm concerned about it, and I'm gonna get that for us.
Addiction's addiction, Add it to the list.
So it's not,
Thank you for the question.
From an online participant from HCH in Manchester. Could you speak more on your statement on Dimension 5 that continued use would mean a lower level of care?
So I'm not saying that, that's a great question. I'm not saying that definitively, sometimes continued use might mean a more intense level of care. What I'm saying is that if you assess the patient, and you ask the questions and you do a full six-dimensional assessment, you find out that this person is just continuing to use. They're not really engaged in treatment. They're more maybe doing time versus treatment. They're not engaged in the process. You're saying to them, all right, I want you to, next time before you use, I want you to do a pros and cons list of why you're going to use, and I want you to have a conversation with someone who supports you not using, and then I want you to call me and leave me a message that explains, why you made the decision. We'll talk about it next time you come. And they come in and they're like, I didn't do that. And you're like, well, and they continually aren't engaged in treatment. You may want to look at, is this the right level of care? Is this too intense for them? Are they better off resolving that ambivalence at a less intense level of care? Because that knee-jerk reaction is to put them in a more intense level of care. Again, this is why we have wait lists for a high acuity level of care, which makes no sense at all, because of that knee-jerk reaction. Like, everyone needs residential, let's put them in residential and let's keep them there for 28 days. If, however, that individual, it's a relapse issue, they're living in a very polluted environment, there's drugs everywhere, their roommate uses, they live above a bar, and their significant other deals, and they are, coming to you and saying, these are all the things that I did before I picked up, and I still am, I'm trying this, I'm trying that, I tried this tool, I tried that tool, and I cannot stop using. This is someone who now you're looking at, okay, well, let's look at IOP if they're an outpatient. Let's look at, maybe a low-intensity residential treatment program with an IOP connected with it. Let's look at a more intense level of care, because this is a relapse issue versus a continued use issue, okay? When you look at someone who has a continued use issue, but is in imminent danger, let's say they're using, what's an example? They're using IV fentanyl, and they are sharing needles without any care for their works, nothing. They are using and sharing needles with everyone they come across, and they just don't, they don't have any regard for it. That's a person who, despite their low level of motivation, may be, based on imminent risk assessment, and that's a whole lesson in of itself, may be appropriate for a more intense level of care. But in most cases, individuals who are continuing to use and don't meet that threshold for imminent risk are more appropriate for a less intense level of care. I'm not saying across the board they are. I'm saying there are individuals who they're doing things, they're engaged in treatment, and they keep using despite adhering to the prescription of treatment that you've provided. Those are folks that are going to need more intense level of care. I think I answered the thing.
Yeah.
I think I don't know. And if not, chime back in, I'll go at it again.
Thank you.
Yeah. Any other questions? All right.
So what we're going to do now is we're going to do some practicing. So first I want to thank Paul for all of that really good information very quickly.
Sorry.
No, yeah. So we had originally prepared 2 case studies for you, but I really want to slow it down and kind of take our time working on this and thinking about it and practicing it. So we're going to start with case number 2 is the one that I picked. This is going to be Mark Smith. So in your handout, don't get confused between Mark Smith and Jennifer. We're going with Mark at this point. So to just kind of set the stage, This case is really intended as MAT providers for you to read through and think about and start to read the kinds of things that Paul writes when he thinks through the 6 dimensions of ASAM and he's talking with a patient. And then as you read through, the precipitating factors, their history, and then how he breaks up this information for each dimension, we have this, worksheet, I'll call it, on the back. And so this is where, after you read the information for the 6 dimensions, you can practice utilizing that the risk rating scale. And so I think that our goal here is to really help you as MAT providers start to think through the 6 dimensions. And then when you start to think about what is the highest risk for those dimensions, that helps you start to think about what other kinds of services can I engage to help meet that risk, to help that person in that dimension, what level of care might be appropriate based on where the highest level of risk is. So that's what we're going to practice now. Is there any questions? Great. All right, so what we'll do is either, if you like to, I kind of leave it up to you if you'd like to work individually or connect with the person next to you or with the people you came with. Read through the case that we have here, fill out the worksheet, and then we'll come together and talk about it. Because if there's anything we've learned from these kinds of activities, we're going to have a lot of different ideas and a lot of different suggestions, and so we'll talk that all through together in maybe 10 or 15 minutes.
Before we I just want to go over one thing. As you're going through here, you can kind of look at the, the clinical rationale. These can really be some problem statements. This is where you can start to look at what the treatment plan might look like going forward.
No, Mark, study.
To the treatment. What? Did you tell me? They were surprised, like, he was trying to tell them.
I got, it's the first time, so I got 5 on one side, 1 on the other, and now I have 4 more.
If you were sleeping, you can be sure that it didn't get near you.
I didn't do that. I didn't either. There was at our house and it was hard to actually, she was actually the one that found it. And then I was like, walk outside. She did that.
Like, roll down, I guess, I think they got the one. Like,
Yeah. Right. Yeah. No. That's why I'm doing that.
I changed mental status, probably inability to control, like neurological stuff, you're gonna get neurological.
I'd have to look it up, but I'm sure I'll start going psychotic. I don't know what to do.
It came up to our room, but it was in our bathroom. We went away, and because we couldn't find it. I'm like, oh God. Just put over. Sorry.
Great.
I thought it was gonna die, so she's like here. And the next day I went and gone. Good boy, survived. Kevlar.
My mom, when she came home before she got a car, she closed the door.
Emotional, behavioral, cognitive conditions. Two or three. I thought it was somewhere around, so. But yeah. That's it. Relapsed. I guess I would put 5 or 8. I guess he's not in a rooming house, so that's probably. He doesn't have good, I don't know anything about it. Oh.
Well, the here and now is that he doesn't have anything No, I'm gonna throw it.
No, I was thinking of really set a couple of, it was last week, because I think a lot of they're not, because they can make money early, they won't have to. recovery coach. I don't even know what that is. That's my life now. Well, have some good lunch. Yeah. Well, we use like, yeah. If I was there today, I was gonna. But I'm gonna start. I mean, I'm open to.
She's not coming back.
What's her criteria? Imminent danger.
She's not
The whole thing.
for any imminent danger. She wants to stay right in her
No,
life.
she was imminent danger. She needs to.
I kind of like the
No
idea.
self-efficacy.
So we'll probably get people that would commit to that.
And then like,
We're gonna see.
and then I like have to go over and I'm like, that's not hunting. You don't she'll be like.
And then maybe we could code it, so like somebody's, we could have their comments.
Right, 5 more minutes.
Kind of reminds me what I used to do. Doing Saturday.
Sounds good.
Now we can read out. But we need.
Yeah, I mean, I know that.
Good name. Oreo?
Yeah.
I knew you were.
They like it.
Well, I just.
Very well.
Right, that's, yeah. My, they lived in and they have.
Well, I know you.
Yeah, one of my friends, Catherine,
We have
died
that.
at 21, I thought that was,
It's kind of weird too, because like, some of my own doctors, and, you know, I look at some of the younger people, and they don't answer their phone.
Yeah,
That's what my concern was, is that. So I'm going to want to question all the time.
Correct, already have. Not a lot more. So you work over at the Elliott? Oh.
Right.
Okay. So they're nice.
Well, I have a story, but the one where I get fired backwards.
Yeah, I was scheduled for 15 minutes on discussion. I like how amendable this meeting's been. We just kind of switched it up as we go. How was that for you? Was that okay for you?
Strong balance. Pretty fun.
It would have been, I think it was a good choice to just do one case. It would have been a lot to do both cases. Really? Yeah. That's right.
There was one side, but the person I the other side. What did I get with you?
And I kept my anecdotes to a dull roar.
You were fairly heavy.
Yeah. It was very hard for me. Progress, not perfection.
Right now. Well, there's like 20 that were,
Yeah.
yes. One of them I already
That was my.
Yeah. A little bit.
All good.
Yeah.
get started. And then what happens?
Yeah, that's what we've been redoing the kitchen, and it's like a little bit. It's finally starting to come together. Yeah. Floors are coming in, and then we're done.
Oh, nice. What are you getting from floor?
Yeah, the cabinets come up good. I don't. I'll show you a pic. I haven't taken a picture. I took it before. Yeah. It's a process, but it came out good, and we did it like super well.
I
Yeah.
feel like that.
And I rented it, or I bought a sprayer, and then I was like, rolling and like, I was like, I tried rolling one, and then like, you could see the imperfections of the spray without spray.
I don't worry about it.
That's what we have. Yeah. All right, so I guess we'll bring it back. If you're, kind of finishing up, that's fine. We'll work together on it. We can schedule another meeting to kind of poke holes in my assessment and find all the faults in it, because, every time most times we've done an assessment, it's like, oh, I went and asked this, or I should have followed up on this, or I should have found out more about, the sister, or, whatever it may be. So, that's all we got, so, we'll do the best what we have. Again, I'm not gonna, there's no right or wrong answers. What I'd just like to do is just talk a little bit about, why you made what you found in each dimension that, kind of led you to believe, you'd give the score that you would, or what are the clinical rationales for specific scores? So, just open it up. Did the client sound familiar? Yes? Yeah, okay. Okay. I tried to find, a couple of folks that, not to say there's a lot of different people we deal with, but there's similar problems that we see. Difficult to engage with them. So what do people have? So I guess we'll start. So if we look at dimension one, what were some numbers and reasons, more importantly, reasons for those numbers that you gave? Did anyone say it was a 0, dimension one?
We did.
Okay. Anyone say 1? Lots of 1s, 2s. So what were the zeros? What was the rationale?
Essentially that, we were looking at the here and now, and, so that, felt like it was an issue, because right now, not having any withdrawal symptoms is not usually very good.
What was the rationale for 1?
That risk is wrong, potential is mild.
Potential is mild, so there was. Yeah. Potential is there.
If high cannabis use, he's used the cannabis 2 hours before he got there.
Okay. So we're.
What he's treating.
Well, yeah, and that's the other thing where we can assess. Now again, that's when we talk about multiple symptoms. Is there intoxication potential? Well, cannabis 2 hours ago. Let's find out more. What kind of cannabis did he use? How did he use it? How much did he use? Is there a chance he's intoxicated at this time? So we can assess for both substances there. Yeah.
Any prior daily use of fentanyl prior to his incarceration.
Okay.
History.
Yeah. So we do want to focus on here and now, but again, we want to get that history and find out what's going on. Yeah. What about for dimension 2? Biomedical conditions and complications. This one could get a little varied. Who gave a 0?
We did.
Okay. All right. What was the rationale for a 0?
He's not systematic, so you have time to get him picked up with, the sources that he needs, but it wasn't a pressing issue.
Okay. Who said a 1? Lots of 1s. What was the rationale for a 1? Okay. Yeah, we definitely want to take that into consideration. We want to find out some safe use protocols of the individual. Hey, when you use, do you share works? Yeah, but I always clean them out. Well, how do you clean them out? Well, I throw a little water in them and shake them around. Or you bleaching them, 3 cycles of bleach, 10-to-1 ratio, do they know what they're doing? You want to find out those things, certainly. Yeah. What other rationale for a 1?
Needs primary care.
Needs primary care physician, yeah. Might not be symptomatic at the time, he doesn't have a primary care physician, and.
Tobacco use, marijuana, that can cause some issues, respiratory issues.
Okay. Well, anyone else, any other numbers, would anyone give a 2 or a 2, 3, or a 4? A 2?
Has the diagnosis, doesn't have CCP. He says he's not symptomatic, but he's expressing irritability, depression, sadness, tiredness, which could be related, just not making that connection that that's what it's related to. So starting him on treatment is only going to help him in the long run.
Okay. So it's important that at the same time, we want to make sure that if we have those suspicions, because that's really good, I didn't think like that, I'm not medical and I don't, that's great to hear, like, I wouldn't have gone there. But we want to, tease that out, is that, we want to ask more questions, like, hey, when does that occur? Is that, find out more if that could be related to a biomedical condition and things like that. But we want to make sure we're treating the here and now. We want to make sure we're addressing what's going on now, because some may come in and say, oh, I've been diagnosed with hypertension, or I've been diagnosed with an anxiety disorder. And we're like, oh, okay, well, you're a 2, you're a 3, automatically. We want to avoid that. We want to avoid treating our own anxiety versus, treating the patient, and be aware of being overzealous with our prescribed care. So we want to find out, what is the here and now, like what's going on here and now. Is it they might be hypertensive, but they're on medication. And again, I know that a lot of times when folks are, in the active throes of addiction, they're not taking their medication properly. But this individual had been, and they're not symptomatic with hypertension. It's managed. We don't want to automatically kind of rate them too high. That's where the 0 to 4 kind of it reminds me of that old gas. Remember the old gas, like. Oh, you just, I know. It's a 50, and you just make sure next time you call the insurance company, it's like a 60. It becomes a little arbitrary. So you want to, that's why I say, the information is more important than the number. So I just want to segue with that. Did anyone do a 4? So dimension 3. What do we have? Any zeros? I know you didn't. Any ones? 1, 1, 1. Any 2s? Okay. So why 2? So what? Some evidence to support 2.
Irritability, depression.
Irritability, depression. Okay. Self-medication. Yep. Sounds like he's using the cannabis to manage that. Yeah. And maybe the opiates as well.
Being described as diagnosed as personality disorder, social personality trait. Could actually be the depression.
Absolutely.
I'd want to be seen by a specialist rather than a PCP.
For any kind of. Yeah, I was hoping some of that, so I put that in there on purpose to see if anyone, hey, they should be seeing someone who's.
Not a probation officer?
Yeah. He was diagnosed by information officer. Yeah, we want to find out more information. We want to talk to someone who's trained in kind of, even the PCP, like we don't, they're great and all, but we want to make sure that it's someone who either the PCP is well versed in psychiatric disorders and mental health disorders, or they got diagnosed by someone who's that's their bread and butter, so to speak. We've done 1, 2. Any 3s? Any 4s? Okay. Readiness to change. So again, I forgot to mention that it was written on the slide. This one's done kind of conversely. So if they have real problems on this, they're not motivated, they have low self-efficacy, they have a lot of cognitive disconnect, they're going to score higher on this dimension. So I think probably people pick up on that. But anyone give a 0 on this one? No? And 1? 2. Okay, a few 2s, yeah. So why 2? What supports a 2?
Some of the big motivators were external, they're still motivators. That can be a high motivator to take your probation officer off your ass.
Yeah, absolutely. Yeah.
Actually, too, it indicates he has no skills, that he really needs some support and skill development, that he has no reason to stop. He says, I don't have a reason to stop, I don't know why I want to. He's only 10 months out of prison, and he has a fear of overdosing.
Yeah. Okay.
And it's talking about a little effort.
Yeah. I threw that in there. I thought that'd be interesting because there are folks that, that he's in jail, he's using a little bit, and it was just more trouble than it was worth, so he decided to stop using. He made up his mind. And that's a strength. And those are the things we classically overlook in this field. As SED providers, I'm talking about myself. Is like, well, look at what they did. Well, they're still using, well, in jail, they were able to tap into something, so let's tap into that as well. Anyone give a 3? Any 4s? Yeah, so would you give different scores for different substances? Like, what about with cannabis use and his opioid use? Different scores here probably, right? So we want to look at that full picture. We want to look at everything, right? Again, pre-contemplative given the cannabis use. I want my card, I want to smoke pot, it helps me, and with the opiates, it's very, very clear that it's a problem. I don't think I have to do anything, but it's definitely a problem. Dimension 5, relapse, continued use, or continued problem potential. Anyone give a 1, or excuse me, a 0? A 1? Okay, 1. 2? 3. Okay, 2 3s. All right, well, why a 3?
Doesn't have a lot of supports,
Not a lot of support.
not a lot.
Yeah.
Doesn't really want to stop, and he wants to avoid the PO in jail.
Yep.
He has no plan on how to stop, he just says, stop.
Okay, no plan. There's no, well, I'm gonna not hang out with Joe and Fred anymore. I'm gonna walk a different way home. I'm going to, my counselor, whoever it is, showed me this app with, all these sobriety tools. This is how I'm gonna do it. There's no plan, And there's some other dimensional problems that are coming into play, and that's an important one. That's where that dimensional interaction comes in. There's not a lot of dimension 6 kind of supports, and that's going to affect the likelihood that they're going to either relapse or continue to use. This individual continued to use cannabis, and we may be looking at more of a relapse issue with the opioids, but this person's not in a recovery state for the cannabis use, clearly. And that's okay. Obviously we don't want to condone continued use of illegal substances when someone's on probation, but we also don't want to tell them what they have to do. We want to say, what do you want? Like, what do you want to do? Well, I want to keep smoking pot and I want to stay on probation. Well, okay, let's check with your probation officer. For those of you that saw Dr. Mia, I love the little like back and forth he does. It's great. That when we talk to the probation officer, well, your probation officer is not really budging on this. He needs you to stop smoking pot. Well, I'm not going to do it. Well, all right, he's probably going to throw you in jail then. Well, I guess I will do it. Okay, so you work within those parameters of that. So what about recovery in a living environment? Anyone give a 0? No zeros. Anyone give a 1? 2? All right, what about 2s? What do people say for 2s?
He's got problems and having the problems of his mom, the work, his partner. Negatives are the friends who go around.
Okay. Anyone say 3? Why do we say 3? I feel like I'm picking on you guys back there. Sorry.
I guess a little bit too.
Well, I haven't seen it so long.
We actually wanted a 2.5 back here, but I thought we could do that.
Even though he has some support, the question how healthy some of them are, like mom's attitude was do whatever you have to do to get off probation. That support or that codependency.
Yeah.
And he thinks it's no big deal at his job, but his boss doesn't know.
Right. Right.
And then his lack of trust is isolating, how is he going to build a healthier support system if he doesn't trust him?
Right. Yeah. And those are things, that's again, that dimensional interaction. So that's, that falls on that kind of that axis 2 kind of stuff. That perceptual difficulty that he may have is going to create problems in his relationships. So you have to look at how the big picture, how the dimensions interact. So what level of care would you guys recommend for this individual? Or what prescribed treatment would you recommend for them? Motivational interviewing, absolutely.
Outpatient, like therapy and that.
So MATV and then outpatient?
Yeah.
Okay, so a combination of the two. Okay, if he's willing.
Getting to see somebody who can
Good mental health, really diagnosed mental health issues.
Okay, yeah, so someone who's appropriate to address any kind of mental health concerns. Yeah. What's that, I'm sorry? Okay. Recovery supports, okay. I don't wanna go to AA, it makes me want to use.
Sorry, there's a lot more than just AA.
You know, so we talked to them about, you know, those things, yeah, there's things out there for you, you know. I don't like any of those groups either, I don't like people, okay, well, what can you do? What are some things that you think might work for you?
Recovery coach checking in.
Recovery coach checking in, yeah. Anyone would recommend like residential treatment facility for this individual? Oh, thank goodness. I don't think it's appropriate. I mean, you know, he's got stable housing and things like that. If those things weren't there, you know, sometimes you could look at a low-intensity residential treatment program so they can resolve some of that ambivalence in a more stable area. But you have someone who's very, very ambivalent, you know, with his cannabis use, and it's going to create problems in that kind of environment.
Zeomite,
What's that?
the zeomite.
And that's where we get into, you know, that's a great point. That's where we get into flux. That's where we get into, you know, the problems is that he feels like, I don't want to smoke pot, you know? And he needs to go to a residential treatment program, like to stop smoking marijuana. And that's where you have to educate the probation officer or whatever mandate it is, wife, husband, whoever it may be. You know, that, well, you know, we need to work with this person where they're at, you know? We can't mandate them to stop doing something. If you're saying you're going to violate him because he's continuing to use cannabis, you know, hey, this is what's going on, you know. Well, I don't want to stop using cannabis. Well, your probation officer is going to violate you, you know.
I happen to live in Mass, so I'm going to throw it out there that it might just not be.
Yeah. 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 But there are folks who use alcohol, you know, and alcohol's, you know, I mean, tobacco, it kills more people than all these things. So, you know, you have to have that conversation with the client that, okay, it's not, you know, like, well, what's your, you know, you want to keep using it, okay, well, keep using it. But your goal is to get off probation and to get your probation officer off your back. He's telling you that he's going to violate you if you keep smoking pot. So this doesn't really jive with your goals, you know. I mean, if you can figure out a way to keep doing this and make your probation officer happy, let me know. Well, I can't really think of anything. Okay, well, we have to revisit and nominate your treatment plan because the way it's written, it's not working. He's not budging on his cannabis.
Well, he said he wants to get cannabis card.
And then you're gonna go through those hoops with him, you know, and that, it's not easy. I'm not like up here saying, oh, well, I have all the answers and this is simple.
But
You know?
for me, this is where you work with the probation officer on harm reduction. Get
Absolutely.
on that path.
Absolutely, yeah. Yeah, you have those conversations with the probation officer saying, as an individual that needs MAT, would benefit greatly from MAT, they're willing to do MAT, and they're even willing to do some outpatient counseling, as long as I don't tell them what they have to do, you know.
Did you, I don't know if you asked him what he likes about marijuana? I don't know if I was, you know, what is it about marijuana that's really, that you enjoy?
Yeah.
You know, relaxes me? Well, remember we were talking about getting PTSD and the anxiety that you have? You know, there may be other ways to address that could, you know, what does that sound like? Is that something you might be interested in? And then you wouldn't have to, maybe you don't have to smoke as much.
And those are the ways you can start those conversations. Yeah, there's a lot of different ways to go at it, because, I mean, these are complex situations and it's a complex disorder as well. And then you add, you know, all the other comorbid kind of conditions that are going on. I just want to, you know, so this is where we can take this, and again, the numbers are great and all, and it gives you a sense, but the information is really what's important. And the information is what you can say, let me look at the treatment plan. And the treatment plan, you know, if your Dimension 4 problem is that the patient is resistant, you really need to relook at your practice, or relook at how you're using the information that's been provided to you. Because the information that was provided to you is that the individual doesn't think that they have a cannabis use disorder, and their probation officer threatened to throw them in jail. There's your problem statement. Okay, now I have actual information that's useful, not this kind of ubiquitous statement that we hear or that we've heard in treatment for a long time. We have better information to create a more patient-centered treatment. So if we understand the problems, which are a clinical rationale for making those determinations, we better understand how we can help the individual. I have this anxiety that I deal with, and I don't know how to, I don't like the medication that they prescribe for me. I feel like I'm swimming through glue, or I'm walking through glue. All day long, that's what I feel like. Okay, well, what are some ways, to deal with that? And if they resolve this, they get a cannabis card, and that's what they resolve to, you work with them where they're at, So I hope this helps people get some better understanding of how to use this information. And I talk a lot about this kind of spirit of ASAM, and a lot of people, what does that mean, And what I mean by that is just thinking dimensionally, thinking in terms of patient-centered treatment, thinking in terms of meeting people where they're at and working with them within what their goals are and what's best for them, and kind of a dimensional kind of standpoint. That's what I would say. So that's it.
Thank you, Paul.
This one's yours. I'm going to walk away with it.
Thank you, everyone, for coming today. We have 2 more meetings this year, one in October, one in December. Save the date. Please remember to utilize the Google group for questions, events, and resources that you have to share. If you're not a member of the Google group and you'd like to be added, please let me know. We'll also try to add you just from your sign-in, so make sure that you've signed in with Melissa in the back, and then she'll also check off that we received your evaluation, so you don't have to get an email from me where I say, did you hand an evaluation and I just not catch it, or do you need this link? It's the whole thing we have to do. So we'll just avoid that, and Melissa will check you off. And thank you for coming. If you have any questions, these are our members of the planning team. I'm Adelaide Murray. Thanks for coming. Yes. Thank you.
Dr. Gasfrin came out, him and his son are working on a bunch of Well, beyond that, that's David's work with ASAM, but his son is
Yes, I actually was looking at